All right. Good morning, everyone. Sorry it took me a little while to get my Zoom going. We're going to be talking about some all-on-four concepts using zygomatic implants. Everyone's familiar with the all-on-four technique. I'm sure a lot of people are doing it. I can't see exactly how many people are on now. We got 32 people. So what I've done is in my practice, I'm going to turn on the Q&A in a little bit because it takes up a lot of my screen. But what I do is, I do a fair amount of all-on-fours, but now most of my practice for the last 10 years has been moved away from all-on-fours, and I do a lot of redo all-on-fours or zygomatic implants. So basically here you can see a typical case. This is a typical all-on-four. I think these are bi-horizon implants, but with that being said, I'm going to get started. Let me see if I can, there we go. So obviously this is a slide that's interesting. All this is about to change, right? With the COVID-19 virus. Obviously, I hope you guys are all staying safe, staying home, not out of harm's way. Back in 2007, implant dentistry comprised $92.8 billion globally. That has grown about 15% annually. So now we're into 2020. Obviously, in this month, that number is going to be probably a tenth of that. It's going to be a small fraction because no one's working worldwide. And who knows what's going to happen and when we're going to go back to normal. But we don't even know what the norm's going to be. But that's an interesting slide. So that curve going up like that is taking a sharp downward turn with the Dow Jones, without a doubt. But with that being said, the U.S. population, we still have a lot of elderly people that, as time goes on, need teeth. And no one likes to wear denture anymore. All-on-fours don't work for everyone. There's a lot of people that present with significantly atrophic maxillas, and for them, we have to resort to zygomatic implants. In 2024, I think about 10% of the population in the U.S. is going to be between 65 and 74. And can everyone hear me? Kate, can you guys hear me?
Market does, and this is how we used to do things. So how did we get here with angled implants and graftless solutions and long implants? So for those of you that have taken courses with me before, you've probably seen this slide. This is an actual case that I did back in 15 years ago. We took a block of posterior hip to reconstruct a significantly deficient maxilla, do onlay and block grafting, screw the bone into place. The zygomatic implants they didn't come around until the late 80s, so this slide was taken in the early 90s. We weren't doing zygomatic implants for reconstruction of mandibles and maxillas yet. For maxillas yet. So what we did here is we would do this big block graft, go back later, and do a big vestibuloplasty, tell the patient they couldn't wear a denture for a while. So it really wasn't an ideal situation. I don't do many of these anymore. And this is another one where we did a kind of a sandwich osteotomy, where we take a posterior hip, shave it to look like a horseshoe, place the dental implants at the same time. Sometimes you'd compress the bone too much, you'd get bone loss around the heads of the implants. It was not an ideal situation. Nonetheless, surgically, it was a fun procedure to do, but no one does that. So how do we get from there to the next slide with zygomatic implants, or the bottom one with quad zygomas? Well, we have Dr. Brandemark to thank for that. But first, we started out with pterygoid implants and the whole sense of having angled implants. Pterygoid implants led to long implants, zygomatic implants, and then later on, we figured we'd tilt these anteriorly to avoid that region altogether, and we came up with the all-on-4 technique. Now, this has been gone through about 20 years. But first, back then, when we used to place pterygoid implants, we couldn't load them anteriorly. Immediately, because they were too far back. And the first one was actually done by a plastic surgeon and not by an oral surgeon or a dentist. But nonetheless, they were placed back in '85 by Paul Tessier. At that time, they had a pretty good success rate. They were just kind of far back. They couldn't be loaded immediately. That wasn't an ideal thing to do back then anyhow. but you can see how far we've come. There's lots of case reports. I don't do a lot of pterygoid implants in my practice. I prefer zygomatics or all on fours, but if I get into an area where I can't place two zygomas on one side, then I'll resort to a pterygoid at times, although there's a lot of my friends that are pretty proficient at them and do lots of them. But you can see the success rate is anywhere from the 60s to the high 90s. And like I said, this is a case where you have 5 implants in the alveolar bone, 2 in the pterygoids. They couldn't be loaded immediately only because they're so far posterior. But in the final, you get a nice result for them. They're loaded on a nice framework, and you get a pretty decent result. Now, with that being said, zygomatic implants are what we're talking about today. So I first started doing these back in probably 2001 or 2002. And Dr. Brandemark started doing these back in 1987. You can see the design has changed quite a bit over the years. The first zygomatic implant was just a straight design, straight implant, and about 10 years later, they came up with a 45-degree one, which you can see in the bottom kind of cartoon depiction coming out. And now you can choose from both. There's an extended range of them. You can get the Brandemark system, which is the original system, or the new Nobel zygomas. And the range is anywhere from 30 to 52.5 millimeters. Now, what happens if you feel like you need a longer implant? Then you can kind of use their angled new abutments, which can give you up to 6 millimeters in height. But that's something that's now been advocated, and some people are using them. So, like as I mentioned, these are implants that now use grapple solutions. I still like to use them only for severe resorption in the maxillary bone for the immediate load protocol. I only like to load them right away. I know a lot of people like to do these in the hospital, in the OR at the hospital. They don't load them right away because a lot of times you can't do that. You can't have a lab there in the hospital, or you can't have someone that's not credentialed to come in there. Generally, most hospitals require you to be an oral surgeon. There are some prosthodontists that are on staff in hospitals, but what happens is we can't do the conversion. And really, in my opinion, when you load these right away, you get the nice cross-arch stabilization, you get a much better result. The failures that I've seen in my hands have been delayed load cases. And so that's kind of something that I kind of want to drive home. I think these should be done in our offices, obviously under sterile technique. And I think that's all about the change as well. I think that we're going to see a lot of changes in the way we do dentistry altogether after all this resolves. But that's a different topic, different discussion. But what we see here is the new 45 and 60-degree angled abutments that allow for deep replacement. And basically, you get better, positioning of the heads of the implants with these, more prosthetic versatility. And remember that these are all external hex connections with the Brandemark implants. Now, here, these implants are designed really more for the, intramaxillary technique, the original technique that was described by Brandemark, and this is actually a little bit more challenging. The new extramaxillary technique that a lot of people advocate is easier, but keep in mind that does not come without its own issues. And I'm going to go over that one as well. But just keep in mind that these implants are designed, you have threads all the way to the top. They're designed more for the intramaxillary technique, and that's the original technique. But you can see here you have 45-degree, 60-degree abutments, and they attach to either the, you can see here with the straight implant, you attach the angled abutment, and with the angled head, the 45-degree head, you can use a 17 or straight abutment, or even a 32. But I generally like to use the 45s if I'm using a straight implant. Nonetheless, here we have a different design, Brandemark, the machine surface. Now, I have only placed one machine surface implant ever with the zygomas. I don't know many people that are placing these, but Nobel still makes them. And from what I hear, they're making a resurgence. My rep said that there's more people ordering these. because there's concerns about the sinus membrane attaching to the tyenite surface and causing inflammatory problems. Nonetheless, this is not something that I use a lot of, but that's something that is in part of your armamentarium. Next, you have, like I said, the Brannemark zygoma tyenite. So you can see there's a difference between this and the original implant. It's still an external hex, but there's more versatility because now you have an implant that can attach a different range of abutments to it. Without being said, it's a personal choice. I stick with the Brannemark zygoma still. You'll see what the Nobel zygoma looks like. So you can see that the threads go all the way to the top, right? So if you're going the traditional way of doing an intramaxillary technique and you happen to push your sinus membrane out of the way so nothing adheres to the threads, when things start healing and the sinus membrane falls back down, they could technically adhere to the surface of the implant, which is threaded all the way to the top, and that can cause inflammatory issues down the road. But sometimes you perforate the membrane, and then the thought process is that the sinus membrane repairs around the threads, and that's an issue itself. This is the Nobel zygoma, which is the latest design, and you can see this is smooth. It's non-threaded on the coronal portion. It allows the extramaxillary technique. So with Nobel implants, you can perform the extramaxillary technique, and like I said, the extramaxillary technique, some believe that it does give you a better prosthetic outcome because the position of the head of the implants is not so far palatal, it's more buccal. I've seen some cases where the implant was also almost at midline, and that's really not ideal from a prosthetic standpoint. Sometimes as a surgeon, you do your best. It's what happens with these zygomatic implants. You always have to have the restorative aspect in mind, otherwise it could be tough. I've actually had one implant myself that I placed years ago, and I thought I had placed a beautiful implant, and then when I went to place the cover screw on it, I thought to myself, boy, this is a little bit too far to the palate. It wasn't quite at the midline, but it was pretty darn close. And the prosthetist I was working with said, hey, listen, we're not going to be able to work with this down the road. So I had to bury it. Taking them out is not an easy thing once they're integrated. So I had to bury it and place another one in a more ideal position. But with the extramaxillary technique, that's less of a problem. Just keep that in mind, and less technically challenging in my opinion. But now you can place Nobel. There are a bunch of other systems out there that and I'll talk about one or two of them as we go along in the lecture. But the other advantage of this new Nobel design is that the apex of the implant is more threaded, and also it drives better than the previous implant. So you get a more enhanced anchorage. You don't get spinners on these. So I have had zygomatic implants that were spinners, but when they get cross-arch stabilized with immediate loading, they integrate just fine. But if you look at the design of this implant, you've got that more aggressive tip versus the old ones that was kind of round. You can see this implant's round at the end. So it's not as ideal. So sometimes the tip of the implant, and I think the reason they designed that original implant that way was because the tip comes out through the peak bone right out here outside the zygoma. Sometimes you can palpate that and feel that. So the idea was to now change that to a more aggressive thread. You don't have to go quite out. You just stop right where your osteotomy ends, and you somewhat get good bicortical stabilization. And I think that's definitely an advantage with doing these that way. Now, with the Nobel zygoma, you can get a straight or the angled head. You can see the difference. Here's the angled head. This is this one. So if you're using a straight one, it gives you a little bit more versatility as far as length goes. You can place that long 60 or 45 degree abutment. So if you need a longer implant, and that does happen sometimes where I do the osteotomy and all of a sudden you want a 57 millimeter implant and you're stuck because the longest one is 52. So you have to redirect and go again. So like I said, whether you're using the Nobel zygoma or Brannemark zygoma, components surgically and prosthetically are interchangeable. so you don't have to have a whole different array of systems or parts available. You can interchange them between the two different systems. So the 0 degree allows us to benefit from the straight implant, as I mentioned, and it's free, which is great. So one thing to keep in mind is with the old Granamark implants, they had a mount. The mount, once removed, was very difficult to replace. So if you place an implant, you're not happy with the position of the head of the implant because your lab or your restorative doctor says, hey, I'm not happy with this, can you go a quarter of a turn deeper? Good luck. Because once you take the mount off the mount-free implants, you are stuck. Now with a mount-free insertion, life is a lot easier because you can back it out or go deeper. So that's one thing to keep in mind. I think that if you're going to be doing zygomatic implants, make your life easy. Go with a mount-free system because that makes life quite difficult for you when you get in a bind. As I mentioned, the new zygoma, the new Nobel zygoma, has that tapered apex that makes it ideal for medial load and bicortical stabilization. What I like about the smooth surfaces, if you're doing the extramaxillary technique, things don't adhere to it, namely the sinus membrane, but I still try to get coverage over these with the buccal fat pad, freeing it up in the medial aspect and of the infratemporal fossa and bringing it over to cover up the body of the implant. And I'm going to, like I mentioned, the Nobel zygoma design, the new Nobel zygoma design is ideal for, you can place it, you could use it for an intramaxillary technique, but I think now a lot of people are using it for the extramaxillary placement. And this way, you can place the implant in a more ideal position. I'm going to show you some photographs of cases that I've done. Here, obviously, you're getting most of your anchorage way up in the zygoma. That's why the threaded portion is limited to that bottom 30 millimeters. Or, in some cases, you're only getting anchorage from about 15 millimeters of bone, so you don't need the threaded portion all the way to the top. Now, here's some long-term data. With Granamark, they placed 110 implants back then. They had about a 95% success. I think they lost some of them very early on, a couple of them, and they lost 3 later on. Now, obviously, if you lose them 3 to 8 years down the road, a lot of times often it's occlusion or a cutaneous infection that leads to implant loss up out at the apex where it comes out the bone. And the early failures are usually surgical failures, as most implants are. Now, like I said, in my hands, I try to reserve them for severe atrophy of the maxilla. Patient can't even wear a denture anymore. Some people are using it for moderate atrophy and now no atrophy at all. Ideally, the patient with no atrophy could be a candidate for a conventional all-on-4. I know some people now are placing Volmers, pterygoids, and one zygoma on each side, which is perfectly fine. I think a lot of it's surgeon preference and whatever lasts longer in your hands. Now, I'm going to show you some cases that I've done here. This is a quad zygomatic implant case for failed all-on-4 in a very atrophic maxilla. So this patient actually is only in his 40s. Unfortunately, had a full mouth extraction, some mini implants placed on the top that failed, conventional all-on-4 that failed. So this is very severe atrophy. Here you're looking at, and you mentioned I don't really talk about the Zygo classification because I look at each case individually, but if you want to go by that, that's perfectly fine as well. But I treat each patient individually, so I don't classify them. They don't fall into a certain category. But here you can see you're looking at the floor of the nose, and the infraorbital nerves are almost at the crest, about half a centimeter away. So with this patient, we basically did a quad zygoma. You can see the lower implants are losing a significant amount of bone, and this patient has a very interesting history. I'll tell you about it. Nonetheless, what I did with him is quad zygoma and immediate load. This was a challenging case, but we got a beautiful result. Now, I learned a lot from this case because you can see here, these are the original Granamark zygomas. And we did the prosthodontist I was working with decided that he wanted to do a full zirconia monoblock restoration. Well, the screws kept on loosening every 3 to 4 months. So the lab was under the impression that the implants are failing. The prosthodontist couldn't figure out why the screws were loosening. But anyhow, the patient had a screwdriver. He kept on tightening himself, which didn't help at all. Nonetheless, the access, so we had to order a special screwdriver because to get to the screws, it was almost 2.5 centimeters. So Nobel had to make a special screwdriver for us to access the screws that are down in the abutments. It was pretty difficult. But this is here you see the final restoration to the left. It's really nice. This is not the, you can see here that it's a huge metal framework. And so this is not the restoration I was talking about. This patient went to Croatia to get this restoration done. But now you can see those 2 implants on the bottom are gone. He had the locators on that. So he went and had a all-on-4 done at a clinic. And they had the implants placed in Hungary. The restoration was done in Croatia. Kind of interesting story. He came back to the U.S. and 2 weeks later called me and goes, "Doc, I think my implants are failing." Sure enough, you can see the restoration in his hand with 2 anterior implants. So I'm not sure what happened, but they did a Nobel Speedy groovy implants there. And the apex of those implants looks like what the new Nobel Zygoma does. And these are the original implants people replaced for all-on-4s. I moved away from them and started doing Nobel Active, but kind of interesting story now. So now he's got 2 implants on the bottom and back to where he started. Now let's talk about a case where I did a combination of pterygoid and zygomatic implants for a very atrophic maxilla. This gentleman had no bone. He's 50 years old, couldn't wear a denture anymore, just was no longer retentive, had no palate. So we had to place zygomatic implants. I apologize for the dark photograph, the facial photo, but you can see how he's got that combination syndrome in the maxilla. It's just awful. So on him, I work with a prosthodontist from the school where I was teaching. The soft tissue dissection is, I can't stress enough, is the most difficult part of this procedure. So a lot of times, you know, you lay this Lefort incision going from tuberosity to tuberosity, and by the time you're done with that, you're kind of exhausted and spent. You need a break. But you're basically extending the dissection on the inferior frontal lateral surfaces of the zygoma, and you have to dissect all the way up there. Obviously, you're preserving the infraorbital nerve on both sides, but you have to, you know, basically be very cautious because you can get some heavy bleeding when you cut the insertion of the masseter muscle. So when I do these cases, I have a Bovie electrocautery in my office at all times. I don't use it for every case, but you know, the very last case that I did, interestingly, back on March 17th, right before we had to close down our offices by executive order, was a gentleman I did a quad zygoma on, and he was on Coumadin. We bridged him with Lovenox. But it was bone dry. I didn't have to use the Bovie at all. A few hours later, he started oozing for the muscles. So it was, you know, it was kind of a cumbersome couple of days to get through. But you know, you have to make sure you control all bleeders anytime you get up there, because it's an area later on that can collect a lot of blood and pool, and you won't know until hours later. So just keep that in mind. If you're going to do these cases, you should have a Bovie electrocautery at your disposal. Here you can see that, and you know, obviously there's a zygomatic notch retractor all the way up there behind the zygomatic notch. And but basically, part of this is by feel. A lot of times, if you have a good retractor, or you know, you're doing this blindly in some cases. But I try to make this is the intramaxillary technique. Obviously, you can see we made a big window, a 10 by 5 infrazygomatic window. The Schneiderian membrane is completely intact. But I'm going to go back to that previous slide. Here you see my dissection goes all the way up to the zygoma. So that retractor you see behind the Minnesota retractor is the zygomatic retractor that I designed myself. I copied the same ideas that Dr. Brandmark had incorporated into his original retractor, but I just put a clear notch in it so that way I could see the tip of my implant when it comes out the bone. I think that's important because that way you know exactly how far you are. Like here you see the big, just to orient yourself, this is our window. We're going to drill this way towards the tip of this zygomatic notch retractor, which makes sense because that way, once you hit the tip of the retractor, you've stopped. That's the ideal time to stop, obviously, with drilling, and then you measure your depth and place an implant. I'd rather go right at the crest of the osteotomy rather than go out, because later on, as some of these patients age, if you violated that buccal fat pad, they get some shrinkage and they start feeling the tip of the implant years later. So keep that in mind when you're placing these implants. There's a retractor that I was mentioning. It's got a nice thumb handle here, so you can hold onto it, lean onto it when you're placing your implant. But if you're doing the Nobel implants, you start with a round burr, and then you drill in sequence. You got a 2.9 drill, and then you have a 3.5 pilot drills, and the final drill is supposed to be, as you can see here, these are not end cutting, so that way you can't cut into the cheek or into the buccal fat pad. But then you have burr guards here. This is very obviously the first case you do is going to be very challenging because this is unlike anything you've done before. So I definitely recommend taking multiple courses before anyone tries to do these zygomatic implants. As you can see here, this patient was intubated. Most of my cases, the patients are intubated, although some people now advocate using an open airway technique. The only problem I have is with an open airway when the patient's not intubated is you can't irrigate as copiously as you want. And the biggest problem with these patients, if they develop a post-op infection, is because you didn't irrigate all the bone shards up there at the tip of the zygoma. So if you have a secure airway, you can irrigate all day long and clean it out very well, not worrying about that. But if you have an open airway and the patient's just sedated, there's only so much irrigation you can do, even if you have 2 or 3 flow packs back there. Here you can see we start drilling. Now the handpiece I'm using here, I'm aiming towards that zygomatic notch. This is one of the original zygomatic handpieces. I don't use them anymore because they keep on getting stuck and you can't even get them repaired. You can't even buy them anymore. Nobel Biocare used to sell them. So now what you see here, the drill guide is in the burr, over the burr, and the burr is inside the sinus going into the zygomatic notch, or going from under the underside of the zygoma into the zygoma. And that's the ideal positioning for these implants. But here you can see I switched out to a conventional dental handpiece. And you can do it just as well with these. Sometimes you just get them wobbling. So keep that in mind. You have to adjust your speed if you're using a conventional dental handpiece. The wobbling, you get that wobbling from the long burr. But what happens is you're drilling, you start drilling at the palatine level, going through the palate into the sinus. We've already got a big sinus with a window. And this way you have good visual control from this, what I call an infrazygomatic window. And then basically you drill from here until you get to the superior cortical layer of the zygoma. So in this case, I think we had good 15 millimeters of solid bone before we got to the zygoma. Same thing here. Now you see here that the trajectory of the implant, it's going towards the zygomatic notch here. This is the patient's nose up here just to orient you. This is the original, I believe, Brandenmark threaded implant. I didn't use the new Nobel zygoma here. And we're getting a nice path of insertion, traversing the maxillary sinus. So obviously, one of the biggest complications that can happen with these implants is penetration of the orbit. There's really no excuse for it, but unfortunately, I've seen a couple of cases where someone penetrated the orbit, and that's never a good day for you. So what I do is, even when I see the tip of that implant with the zygomatic notch retractor, I always double check digitally, run my finger from the outside over the infraorbital rim to make sure that I'm in the right place. Because you'd be surprised how close the orbital rim is to the zygomatic notch. And if you're not cautious enough, or if you're not doing guided zygomatic implants, then you can get into trouble there. But just keep in mind that it's something that you have to just check multiple times throughout the surgery. in order to avoid having problems. Here you can see the implant going into the correct position. This is the opposite side. So what I try to do is when I place 4 posterior zygomatic implants, I try to at least have 1 implant anteriorly to prevent rocking of the restoration down the road, that seesaw effect. Now, obviously if you don't have sufficient bone, then you're stuck. You have to do just 4. But here you can see what I was talking about, where I have a screwdriver trying to remove the implant carrier. So once this implant carrier is removed, you cannot reposition this implant again. It is going to be stuck where you placed it. So that's why nowadays I'm using mountless zygomatic implants. The brand is really irrelevant, but almost all of them now have a mountless dental implant. So that's what I would recommend you proceed with. Here we have, I believe, 4 implants, and I placed, on this case, I even placed some pterygoid implants for this gentleman, but we'll see. So this is in 1 week post-op, and this was not, this was 6 implants. So I think this gentleman got a bilateral zygomatics, bilateral pterygoids. The final, yep, there it is. So you have 2 anteriors, 2 zygomatics, 2 pterygoids. I prefer doing quads, but in this case we did pterygoids on each side too. That was a teaching case, so we were placing zygomatics and pterygoids. But ideal result 1 year later, and I'm sure he'll be back to the bottom at some point. Now, that was a Nobel case from start to finish. I'm going to show you some other systems as well. So when we do a quad zygomatic implant for failed onlay, this is a patient that when he was young, he had a very atrophic maxilla, had a car accident, was even worse. So they did a Laford osteotomy with onlay bone grafting, which all resorbed because he was pounding on it with a denture. And anytime you do a big rig augmentation or a big bone graft like that, if you're not taking advantage of that bone early on and placing dental implants, you're going to get resorption by pressure. So you lost the whole bone. We did quad zygomas and 1 anterior implant you see here to prevent rocking, and he's done very well. Now here's another case of quad zygomatic implant and a single anterior implant. So this patient's obviously been wearing a denture for a long time. Not quite as bad as one of those first cases I showed you. Same thing. We did 4 zygomatics, 1 anterior implant. I prefer to, if I can, to do the 1 anterior on either side or even midline to prevent rocking. Similar case. This actually is an interesting case. This is a gentleman that had, a young lady, I'm sorry, who had some traditional zygomatic implants placed by a colleague. Unfortunately, for whatever reason, that left-sided implant, the patient states that they thought it was in a car accident they got, their face hit the steering wheel. That could have happened. So you see 1 implant went straight into the nose, and the other one was pretty much separated and into the nasal cavity. So we had to remove those and place 2 more zygomatics. There was no bone anteriorly. The problem with a case like this is the previous surgeon, really never had an intention of placing zygomatic implants. So they placed their 2 anterior implants there. I had to crisscross those implants to get good bone to do a quad zygoma. So it was very challenging to do. But you can see my implants go on the underside, and I was trying to come out in a good palatal position as well. But nonetheless, this was a difficult case. Anytime you do a redo, whether it's your own case or someone else's case, those are difficult. And I don't do any guided zygomatic implant cases, but I think this would be a good case to do as a guided zygomatic case. For years, everyone's been trying to come up with a truly guided zygomatic implant case, and they never really met the stringent criteria to develop something good. Now I think there are a couple out there. I just haven't tried it myself yet because I'd rather see exactly where I'm placing my implant and know I go by feel. Now, we get to this new system, Norris Medical. So Norris Medical is designed for purely extramaxillary techniques. And basically, they streamlined it and made it very easy. So I've moved the board's using a lot more of their implants to place extramaxillary zygomas. It's a different kind of technique, and I'll go over that as well. Now, for some people, this works very well. For some people, they prefer to do the intramaxillary technique. There's no right or wrong way to do it. There are different ways. But you can see here, the idea is to have this long, clean cylinder that is a machine surface with no threads. Avoid having soft tissue adhere to it or cause any problems down the road. Here you can see this is a cartoon depiction. I'm going to show you some cases where I've done. So the good thing about this system is that it's got a very aggressive thread pitch at the apex. So as opposed to the previous systems, which had small grooves and smaller threads, and sometimes you'd have to go out the apex of your osteotomy 2 to 3 millimeters to get good stabilization to prevent spinning. With this implant system, you don't have to do that. Now, I have started under drilling my osteotomy slightly in order to get good stability, but that is, in my hands, that works very well. And the platform attachment is a Zimmer type attachment, so it's kind of almost interchangeable. Some people can use Zimmer abutments and cylinders that go on top of them. But the indications for use, like I said, same as before. Significantly atrophic maxilla is the ideal scenario for these. And these come straight from their catalog, some of these slides. And obviously I'm going to be able to share my presentation down the road. If anyone wants this, we're more than happy to share this with anyone who can shoot us an email. But the difference here with the extramaxillary technique is you get a much higher insertion torque because the implant's different. That has nothing to do with the intro or extramaxillary technique, but it's just a more of a active thread. This implant looks like a Nobel active at the apex. And the other ideal thing is the prosthetic platform is shifted more buccally because you're going extramaxillary. You're not going to, you still have to be cautious not to place a really long implant to end up in the palatal position. But the good thing is that here you have that clean cylinder and you don't have to worry about sinus membranes or anything attaching to it. This is, it also comes with a wide array of abutments that you can attach going all the way from 17 degrees to 60s. But I find that the 42.5 is the most common one that I've used in most of my cases. And it comes in a length from 30 to 57.5. The 60 millimeter one is not FDA approved in the US yet, but they come in 2.5 millimeter increments, and it's got a 2.4 millimeter internal hex Zimmer type attachment. So as I mentioned, you can use Zimmer parts. I wouldn't say use Zimmer parts, but if you're in a bind, you can't find something, then you can resort to that. This is what the implant looks like. I'm going to get to some cases because this comes straight from the catalog. And if any of you have been in any of my courses, you've probably seen some of these slides before. But what I like is, like I said, the deep threads gives you excellent stability. The primary stability is amazing on these implants, just because it's a very active, implant. It's a very aggressive implant. So, why the extramaxillary technique? I think a lot of people are parting ways with the old intramaxillary technique because there are complications that can result. There's a lot of patients that end up with sinusitis, cutaneous fistulas, because the implant had to be placed a little bit deeper, and you bypass the sinus altogether. I've had a couple of patients over the years that I have to refer to an ENT for sinus surgery because, 4 or 5 years down the road, they develop sinus problems. And obviously, the prosthetic positioning is more ideal. So you avoid the sinus, you avoid cutaneous issues, and you have a more ideal position. So it's kind of a no-brainer, but there are some surgeons that are reluctant to try this technique because, it's not the original Brandenburg technique. But like I said, it's a personal preference and what works best in your hands. This is the kit. This is the older kit now. I think now they came up with a newer kit. I think myself and some other surgeons made some suggestions to them to make some changes. But what's nice about these burrs is the burrs also work as a depth gauge for you. So if you are placing these breast implants, you don't have to take out your burr, place in this drill guide, although I do it every time because there are markings on here. So the burrs come as 1, 2, 3 with different diameters, and they also have these diamond cylinders. So because this is an extramaxillary technique, if you're placing this implant on a patient with a zygo 1 or 2, I told you I was going to talk about that, but here I am. But if you have someone that doesn't have such an atrophic maxilla, you're going to have to create that groove or cylinder to allow the implant to be placed properly in the zygomatic bone, yet come out in an ideal buccal position. So sometimes you have to make a deep groove in the lateral wall of the maxillary sinus. So you use these diamond burrs. I start with a coarse, and then a medium, a very fine one. I hardly ever have to use a fine burr. I make my groove with a coarse or medium. Also here, looking here, you have the 1, 2, 3. If you are working on someone which has a very dense zygomatic bone, you're going to go to the 3rd burr. I hardly ever go to the 3rd burr, and I place my implant after I'm finished with the 2nd burr, the number 2 burr. So the only difference here is medium or short and long burrs. I think now they have a 3rd length. They have short, medium, and long. I do not have the new kit, but that's what the old kit looks like. So this is supposedly this is a grade 5 titanium. Most dental implants in the past have been grade 4, so this is a grade 5. So it's better tensile strength and supposedly superior biocompatibility. Although I have yet to have a problem with grade 4 titanium implants, but this is another plus and selling point from the company. I'm not going to go over this electron microscope, but they talk about the residual blasting the surface, and it gives you better topography when the bone attaches to it. Like I said, this is a company claim. I haven't looked at the research itself, but I just wanted to make sure that I put it out there that it's perfectly biocompatible with any other dental implant system. Now with the zygomatic implant in mind, so keep in mind here that now you have an internal connection. Some other dental implant companies have now moved away from that external hex to a more ideal internal connection. I think that there's 3 or 4 other competitors that make zygomatic implants, and they've all done the same thing. So the zygomatic implant now comes with an internal hex, and it's longer. So that's kind of more ideal for placement. Here's the length. I said 30 to 60. I have yet to see the 60, but I have placed a couple of 57.5s. This is the burrs. So you see here that the burrs are 1, 2, and 3. So you can see the diameter is different at the head of the implant. So if you're drilling with the burr number 1 and 2, the sequence is 1, 2, 3. But let's say the first burr you go to length. You see where the yellow portion of the tip of the burr is. You should drill it all the way down to the ideal position and obviously ideal length. The second burr is supposedly obviously a little thicker at the tip. So I've had a couple of cases where I felt when I was drilling that the bone was so soft, and I decided that I would hold back on my second burr, and I went to place the implant, and I got good primary stability without having to drill. Now keep in mind, if you under-prepare an osteotomy and you go to place these implants, if you over-torque, you can fracture the zygoma. So keep in mind, that's a possibility. You kind of have to balance the drilling technique and the placement, because if you under-prepare and you over-torque, you can actually break the zygoma. So please keep that in mind. It's better to complete your osteotomy to death, but you don't want to get a spinner either. So with that, like I mentioned, I rarely use the third burr. If I have to use it, I stop about 5 millimeters shy. So obviously this is ideal for a 60 millimeter implant. So if you're placing a 60 and you drill back, you kind of go down drilled by 5 millimeters. So let's say if you're placing your first burr, you go down to 42.5. Hey, you know that it's going to be a 42.5 millimeter implant. On your second burr, your drill, you can try to under drill by 5 millimeters just to get that tip going. Because the tip is the part that's a little bit thicker. And if you try to place your implant and you feel like, hey, you're putting too much pressure on the zygoma, take the implant out and then drill with your third. But like I said, I never go to full depth with the third burr, just to keep that in mind. It's not one of those things that I think you need to do. This is that same, obviously, picture just blown up. And here you can see why. So obviously most of our cases are, like I said, the zygomatic bone is somewhat dense. So this is the scenario usually. So if you take that second burr, you're going to drill about 5 millimeters shy of the final depth to get your implant in an ideal position. Oh, I'm sorry. So I'm going to move on to some clinical cases. I'm going to answer some questions at the end. This is the surgical kit outlined. It's kind of nice because it comes in a nice kit, nice box. I think Nobel is now going to be making a kit or box for the burrs to be placed in, although I think now everything going on, I think implant dentistry is going to change, and we'll be looking at single-use burrs for almost every single case. But this is the kit that I was talking about. This is the new kit where they have 3 sets of burrs, 1, 2, and 3, different diameters, 2, 2.8, and 3.2. You saw that my kit only had 2 sets of burrs. This is the older kit from a couple of years back. So if you're getting the new kits, the new implants, you're going to have the 3 sets of burrs in there, and the diamond burrs are a little bit longer now as well. So the diamond burrs are to create that extra maxillary channel in the lateral alveolus, and you can see how there's coarse, medium, and fine. And these diamond burrs have I've done at least 20 cases, and they don't wear out. They're still just as sharp and cut just as well as they did when I first started using them. So I don't know what kind of lifespan these diamond burrs have, but in my hands so far, I haven't had to replace them. So this is all the different ways they have. So they have all different types of abutments, which is kind of nice. The cylinders they come engaging and not engaging like the other systems. But the good news is you have a wide array of the angles. So here you have straight all the way from 1 to 5, and you have the angles all the way from 2 to 5 millimeters. So if you use 17 or 32 or 42.5, I'm sorry, 17, 30, 45, 52, and 60 degree abutments. I have not had to use a 60 or a 52 yet, although we've used quite a few of the 45s, and those are ideal for these zygomatic implants. For some reason, almost every single one of my cases I've done has been 45 degree abutments. This is just their entire line. They have implants, so pterygoids. These are actually interesting. These are for the pterygoid implants, specifically made for pterygoid implants, and the same abutments fit on them. Or you can just use a really long implant if you're not wanting to use this. In the past, what I've done for pterygoid implants, I've just used long 18 to 22 millimeter Nobel actives. These come in that range. They come 18 to 25 millimeters, and this collar is smooth, so it's ideal for placing a pterygoid implant going through that thick tissue. Here you have the good thing is you have a guide pin, so when you don't have to open an abutment and keep on trying them out. These are sterilizable. You place these over the in the implant, you or your lab or your restorative dentist or whoever's doing the conversion. So that way you get a good idea of what kind of implant abutment you have, so you don't have to keep on opening and closing it. Like I said, similar systems to this implant are Nobel, Southern, and I think that Neodent also has a new zygoma implant, and I believe Straumann's coming out with one too. And like I said, I'm not advocating one over the others. In my hands, I only use the Norris and the Nova Biocare. I have not used Southern, although I recently used a similar system in Brazil a couple of months ago, and it looked like Southern implants that had threads all the way at the bottom. And then again, it had 5 millimeters of threads all the way at the top, which was interesting because if you were attaching to the alveolar bone, you could use it for engaging the alveolar bone. So it's kind of an interesting setup that way. This is the protocol, very similar. You drill your pilot drill, then you make your slot in the lateral wall of the sinus. You go from the underside into the inferior portion of zygoma, come out to the posterior portion, and after you place your implant, it's very similar to what we went with the previous with Nobel and did the conversion, but these are obviously ideal for immediate loading. I'm going to show you a case here. This is obviously comes from their website, but you can see how the groove that you create. So first you create this round pilot hole up here. You take a nice coarse diamond burr, make this in the lateral portion of the sinus, and you push the sinus back, place an implant. Now, what I do is some people like to place their anterior implant first. Some people like to place the posterior one first. I always try to place the posterior one first and go as vertical as possible, so I have plenty of real estate left for my anterior implant. Because if you place this posterior implant not far back enough, you can't do a quad zygoma because you burn valuable real estate up here. So here you see one zygoma placed, then they place a second zygoma, and I believe there's a pterygoid there as well. And here's some bone probably with HA. I don't use that to cover the cylinders. So one of the things with these extramaxillary implants is sometimes patients will complain about feeling the cylinder in the cheek. So you cover it with a buccal fat pad. Some people do bone. I don't do a bone graft there. I would rather use a buccal fat pad over it, and that way you cover it up completely so they don't really feel that over there. Now I'm going to show you a case. Let me question. Okay. Well, that was it. We've done that already. Let me see if there's any other questions. Not yet. All right. So yes, we did mute those backgrounds. Hopefully there's no more background noise at this point. I think with that being said, let me go to the next slide. So this is we've done a bunch of courses. This is one I did way back a year ago. We did one live surgery course in Brazil last year. I was supposed to do one in Miami last weekend, but obviously we didn't get to it because of the virus. So we've gone from this to this to this, and now this is a case that I just did not long ago. So here you see I got a patient. I have my anesthesiologist in there. They're pre-oxygenating the patient. This lady was intubated. She's young. These are young patients that are edentulous. Failed all on 4, and now comes in for a zygomatic implant. So she's got a moderately atrophied maxilla, but it just didn't look like an ideal case for an all-on-4 redo because she had already failed. So I was just going to resort to zygomatic implants. Big LaFord incision. You can see here now I spare the anterior incisive papilla here because what I don't want to do, I have 2 separate incisions, one on the left, one on the right, because I want to be able to reconnect this. This kind of gives me a good semblance of where my midline is as well. So here you see ideal LaFord incision going all the way back. Nature incision, with, here I use a blade because not everyone's going to have a Bovie cautery. But like I said, I recommend having a Bovie electric cautery in your office. So incision reflected both sides, go all the way up to the zygoma, place the zygomatic notch retractor. At this point, you use your round burr, which is now included in the kit. So here you see the most posterior implant's going to be almost vertical here. So, and then we make a slot to join where you want the head of the implant to be. So where it's going to enter the zygoma, you make a deep groove in the lateral wall of the maxillary sinus without perforating the sinus membrane. Now, with that being said, have I ever perforated it before? Yes. And a lot of people think that it doesn't make a difference. I just like to try to stay away from perforating that. Long term, you could get sinusitis issues. It may not affect the implant, but it can definitely cause sinusitis. So here, my lab makes me a clear guide, duplicate of the denture. You can see the head of the implant is going to come through here. That's an ideal position, almost like a conventional all-on-4. I use a 4 molt curette to move the membrane away from my osteotomy. Here you can see the buccal fat pad in the background. We're going to free that up later and bring it over the implants. But here you can see the implant going into, well, we haven't placed the implant yet, but let me go show you these things. So these are cottonoids that you can order. I use them in the operating room of the hospital for when I do orbital surgery. But what happens is when here you push the sinus membrane away, when you're doing your osteotomies, you can actually drill into the sinus membrane. So to push this away, I take a cottonoid and I just pack it in there and move the sinus membrane away. So if my drill happens to engage anything, it engages the cottonoid. And these are radiographic markers. That way you never have to worry about losing something, like a piece of gauze. I have cut pieces of gauze before and packed them there in the past, but those can get lost. This won't get lost. It doesn't fragment or tear. You here see it's being packed in there really nicely. Then we go ahead and make our osteotomies. Here you see I pack it in there, push the sinus up, and the sinus kind of stays away. Here we're pulling it out. So these are cottonoids that you can get from any surgical supply company, I believe, and it basically serves a purpose. It's like packing cords. Same thing, same concept. Keep blood, keep the soft tissue away from your osteotomy. And now you can see here we place the drill in there on the underside of the zygoma. We're doing our osteotomy, and the sinus membrane is pushed away. Here now, if you happen to grab this cottonoid, you haven't done any damage because it's pushing the membrane out of the way, and you grab this, you just replace it. Here you see one of the zygomatic implants being placed, and this is what I was talking about with these burrs. When you're drilling here, this is at the crest of the alveolus. So this is 45, this is 50. So most likely you pick the 47.5 millimeter implant. The tip of the burr is hitting our zygomatic notch retractor. That's kind of hard to see. You can place this with a hand piece or by hand. Here we're driving it in by hand. You have one zygoma going in slowly. You won't see it here, but we irrigate. We take breaks to irrigate this. Now, what I want to show you here is this is a case where I under-drilled this. So look what happens when you under-drill. Here we cracked the lateral zygoma. So I just want everyone to see this. So this is a case where I only used the burr number 1 because I didn't want to have a spinner, obviously, and this is one of the first cases I did with Norris Medical. So I actually got a green stick fracture in the zygoma. That healed without a problem, but I just want you to keep that in mind. That's why now I use burr number 1. And burr number 2, I just stop 5 millimeters shy of my final length sometimes for these cases, but hardly ever do I have to use burr number 3. Now we're going to go anterior to that to place our second implant. Like I said, place the first implant is posterior, second one's anterior. Here we use the depth gauge to measure, see how deep our second zygomatic implant is going to go. And you have 2 on this side. Once again, we check with the clear guide to see exactly where our head of the implant is going to come through. And I think it's an ideal position so that when we go to the other side. Here we have 2 on the right, 2 on the left. So you can see on the left side, I basically made a bigger window. You can see one big window here. On the other side, we have 2 separate clear channels. And we have a quad zygoma here. And now we go to place the abutments. You can see here the abutments. They go and they have a little handle. It's very easy. It's just like a conventional MUA where you place it. If you're not happy, you reposition it. But now with the old external hex ones, it was very difficult to change the position of the abutment if you were not happy with it. So here we have 4 abutments, good draw, nice and parallel. These are all 45s, I believe. And my lab and restorative dentists come in to check the bite. They do a pickup here, and then they start doing the conversion, obviously in the lab and chair side. Now in this case here, we did a bone graft. I took an empty syringe, took some bone, putty, and placed it over this exposed cylinder. And on the other side, I think we did the buccal fat pad. This is one of our first cases. We're taking photographs for a book, so we want to have all the different options on the table. Here you see the denture being converted. This is your before and after of a case like this. So you can see the extramaxillary technique, I think, is a little bit easier than the intramaxillary technique. And definitely do multiple courses before I start placing these implants on patients. It's a little bit more technique sensitive. You can see the tip of the implant is actually close to the infraorbital rim, but the implant's going in the right direction. I know some people that will place one anterior zygomatic implant and engage this infraorbital rim purposely. I don't do that. I just maybe I'm just not gutsy enough. Dr. Cesar Guerrero, who's a friend of mine, he does them, and more power to him. That's not something I want to do unless I absolutely have to. And I think this is her occlusion when she woke up. Obviously, she needs to have her bottoms done too. But you can see here the buccal fat pad is reached over to cover the implants, and you can bring it all the way to the midline. So this patient actually has a really nice satisfactory result. She's almost a year out. I think with that being said, I'm going to open up for questions. Sorry, I went over an hour. So let me see here. Oh, the main reason I think that I'm seeing, do you want me to talk or do you want to type? So I think the main reason why I'm seeing all on 4 cases failing is one is inadequate bone reduction. So the restorations break. I've seen patients that come in with broken restorations all the time. And I think one of it's inadequate bone reduction. The other one is, I think it's, obviously it's operator error. The case I just did a few weeks ago, the implants had no buccal bone on them. So if you're placing your implants in a position that's not so ideal, you're going to get more bone loss if the occlusion is not right. But I think a lot of it's operator error in technique, and I think it's like anything else, the more you do, the better you get. We can all go back to look at the cases we did 20 years ago when we were in school or even before that, and you wouldn't make the same mistakes again. But I think it's operator error. In my case, I irrigate copiously. One of the biggest things that I've learned is I irrigate like crazy. And before I close, I irrigate a lot to prevent any kind of bone debris or bone shards, whether I'm doing the all-on-4 or zygomatic implants. I just make sure that the area is really pristine and clean before I close it. And that's why I like to have these patients have a secure airway. I think the other reason why these zygomatic implants or any kind of implants fail is occlusion. Almost every case that I've seen fail has been due to occlusion. So the occlusion has to be adjusted. I had a case that came in a few weeks ago, and I had placed the implants. Obviously, the patient was asleep. So when we adjusted the occlusion, the poor patient waking up looked like she had nice, even contacts all the way throughout, but her bite was actually different. So she came in for follow-up. I see them for follow-up once a week. So I saw her a few days later, and with the COVID-19 going on, obviously the dental office was closed. I noticed her occlusion was only on the end to front 4 teeth, and that's not ideal. So she had a slide from CR to CR, so we adjusted her bite, so she had a nice balanced occlusion, and it obviously, longevity-wise, it adds to the life of the implants. So you have to make sure that your occlusion is balanced. I think heavy occlusion is the #1 reason why these implants fail. And then, obviously, operator error, and then improper technique.